We are from UK Adolescent Medicine, and we're going to be talking about teen suicide prevention. We have no disclosures, and these are our objectives for today. Suicide prevalence. Suicide is actually the second leading cause of death in youth between ages 10 and 24, so it is extremely prevalent. There is 5,723 deaths in ages 15 to 24 in 2016. Can you hear me? Okay. More teenagers and young adults actually die from suicide than the combination of cancer, heart disease, AIDS, birth defects, stroke, pneumonia, the flu, and chronic lung disease. So you can see it's extremely prevalent in the teenage population. And each year we see about 157,000 emergency room visits for self-inflicted injuries. Kentucky's actually number 20 in suicides, and they had 756 deaths associated with that. 4 out of every 5 teens who attempt suicides have given clear warning signs. So just to see how important it is to be aware and look for those warning signs that we'll talk about later. And 1 of 3 suicide deaths is actually not the individual's first attempt. So there are several different signs that we can look for in identifying teenagers that are contemplating suicide, or things that we need to be looking for. Some things is they will actually come out and express that they are considering suicide, are thinking about different ways that they may attempt to kill themselves. They may have increased substance use, increased drug use, may see mood changes like increased anger, more reckless behaviors, things like that are oftentimes warning signs that we see with these patients. Sometimes they will actually express direct statements, such as saying, "I'd be better off dead, you won't have to worry about me when I'm gone, I hate my life, I'm going to kill myself." And oftentimes it is through indirect statements as well, such as social media or text messages, emails, things like that. There are several different risk factors that we see that can increase patients' suicide risks. So patients who have a history of sexual assault, maltreatment, people who are bullied or have violence among their peers, polyvictimization and previous attempts are actually the greatest risk factor and greatest predictor that we see. And there is a dose-response relationship to childhood adverse events and suicidal behaviors. Oftentimes, a risk factor is having 1 or more mental or substance abuse problems, impulsive behaviors, a family history of suicide or a family history of mental illness, family violence. Having guns in the home is an extremely important risk factor as well. Imprisonment and then exposure to the suicidal behaviors of others can play a significant role as well. So these are some things that we like to mention just for when to know when to ask for help. When a teen may feel and express extreme depression, anxiety, fear, or anger, things that feel out of control, they're hearing voices that others don't hear, seeing things that others don't see, or things like not being able to sleep or eat for 3 days in a row. So when we see these patients, of course, call 911 if teenagers are actively suicidal, have thoughts of suicide, plan, and the means to carry out that plan. And then we always have the National Suicide Prevention Lifeline that we always give to our patients as well. So this just goes through a little bit about the cognitive development behind the adolescent brain, so we can kind of identify how their brain works and how that cognitive development plays out as they get older and how that affects suicide. As these teenagers are growing up, their thought processes go from concrete to more abstract. They have increased memory skills, and their orientation in time goes from present to future. And they can also have, as far as causality goes from single to multiple. Cognitive skills for abstract thinking, just multiple meanings, alternative possibilities, hypothetical thoughts, things like that. And as far as different perspectives, it's interesting to see how, as development goes on, how perspectives change. So typically, initially, teenagers will say there's only one perspective, and that's mine. As they continue to grow up, there's two perspectives. There's my perspective and your perspective, but I'm only thinking about mine. And then at the end, they can think about multiple perspectives and take all of those things into consideration. This is interesting because it's actually been thought that by adolescence that the brain is fully developed. However, recent research has shown that brain maturation is actually not complete until age 24. So when you think about development in teenagers and those impulsive behaviors, things like that, their brain is still developing at that point. So it's very interesting to think about that and how that affects their decisions and behaviors. This explains the frontal lobe of a mature brain. So the frontal lobe of the mature brain, is functioning as the control center of the brain. So they have the ability to avoid those impulsive behaviors. They can promote discipline and control. They are able to avoid those risk-taking and impulsive behaviors and control their emotions. Also has higher intellect, and they're able to consider the consequences of their actions and how those actions will affect not only themselves, but other individuals as well. In the adolescent brain, you can see there's a lot going on in this picture. So they have, of course, the friends, the peer pressure, what they're gonna do in college, what sports activities they're doing, all of those different things, what they like to do for fun. It's there's a lot going on in their brain and it's still developing, so it can often be difficult to really say, how am I gonna make those right decisions and avoid these impulsive choices? So in the adolescent patient, the frontal lobe, those things aren't fully developed. So control and regulation are not developed. That can lead to risk-taking behaviors, impulsive behaviors, lack of discipline, kind of this emotional chaos that's going on. And so they have that thrill-seeking behavior, and they're not able to consider the consequences associated with those behaviors. There's 3 pathways through adolescence, and those things are based on brain chemistry and environment and maturity. So we like to think of them as initially there's the small, fairly smooth roller coaster, and then next there's the small roller coaster that has some occasional rides that are on more larger, terrifying roller coasters. And then lastly, there's the individuals who continuously are on that large, terrifying roller coaster. So the small roller coaster is about 20% of adolescents. These adolescents are usually well adjusted. They're meeting the demands of the developmental stage, and they always seem to know kind of the right thing to do. And in the middle here is about 35% of adolescents. So these patients are usually reasonably well adjusted. They will often have difficulties if there's an unexpected event or trauma that happens in their life, such as the loss of a loved one or death of a pet, divorce, things like that make it more difficult for these patients. And then, of course, there's the large roller coaster that's actually 42% of adolescents. So this makes up the largest portion, which is adolescent turmoil, those high-risk behaviors, impulsive behaviors. These patients are more at risk for things like alcohol use, drug use, more risky behaviors. So, like we talked about, the front of the adolescent brain is not fully developed, so it's hard to really step back and say, okay, this is not the right choice, it's an impulsive behavior, what are the consequences associated with this behavior that I might be doing? So it's important to stop and think about that. And like I said, they have that lack of ability to stop and think about these decisions. So they often like the thrill seeking and the impulsive behaviors. And oftentimes with these patients, it's important to think, in discussion with parents and caregivers, oftentimes what adults see as problems, adolescents will see as solutions. So adolescents and actually adults often do not give up their solutions that easily. So it's important to think about when a patient comes in and they're discussing these things with you, how important these conversations are and how it actually affects them. Electronic use has become a huge player in suicide and mood issues just because of so much more availability and so many more people getting involved with social media. 86% of young adults, most are teens, 71%, and 25% of those 8 to 12 actually have a Facebook account. So the majority of patients are online using social media, and the average teenager sends about 3,705 text messages per month. So that's a huge number. Most teenagers prefer to talk with their friends via text messaging, about 54%, as opposed to calling them on the phone or seeing them in person. So most people prefer to do electronic communication. This can lead to very, very serious effects from this. Cyberbullying is increasing in prevalence, sleep deprivation, sexting and sexual victimization, internet addiction, more widespread things like inhalant use, the choking game, all of these different apps that present with risk-taking behaviors, and digital stressors. So digital stressors, they can be things like impersonation, receiving mean and personal attacks and threats, public shaming and humiliation, breaking and entering into accounts in different devices, and that pressure to comply with peer pressure. Oftentimes teenagers will have this pressure to keep up with social media, to have a certain number of posts and to be active and have enough posts that their friends see and get likes and things like that. So there's a pressure to really keep up with all that, and it can be extremely stressful for these patients. So we always encourage parents to be aware of what their teenagers are using as far as apps and how much time they're spending on their phones. Parents are a good role model for their children and how to be safe and use their cell phones. We encourage no cell phone use at meal times, things like that. Not to use cell phones when they're taking their children to and from school, and then to have about an hour or so after they get home from school that parents aren't using their phones, children aren't using their phones, to actually use that time to communicate with them by talking, have conversations about the day, things like that that you can't necessarily do when everyone is glued to their phone. So the actual definition of cyberbullying is any deliberate behavior performed through electronic or digital media by individuals or groups who repeatedly communicate hostile or aggressive messages intended to inflict harm or discomfort on others. This is an interesting statistic as far as how many patients actually have received mean or threatening emails or other like text messages, things like that. I don't know if you guys can see, but this is 4th through 8th grade. So these are young kids. By 8th grade, it's about at 25%. So that's a huge number of kids who are experiencing these threatening messages, and it's a very stressful and concerning statistic. So it's important to be aware of. This is actually data from the Kentucky Youth Risk Behavior Survey, where they looked at the youth and how they were affected by bullying. There's 48.9% of middle school students reported that they had been bullied at school. So almost half of our kids in middle school are reporting that they're being bullied while at school. 24.8% reported that they were bullied online. So also a huge statistic. There is a resource that we can give parents. It's stopbullying.com, and there's different resources and recommendations that our parents can look at. And also important just to talk to our kids about internet safety, not friending people who you don't know, not meeting people in person who you've just met online, safety things that are so important to keep our kids safe. Cyberbullying not only can increase the risk of suicide, but there are so many other problems that it can cause as far as academic performance, skipping school, weapon carrying, detentions, referrals, expulsions. They're more frequent when students are actually harassed online. Depression, social anxiety, low self-esteem, those are all things that can be increased with cyberbullying. Also things like headaches, recurrent abdominal pain, sleep difficulties. These kids oftentimes don't want to go to school, so we see them a lot in our clinic for similar things like the headaches and abdominal pain. Warning signs are sadness or anger after the patient has been using social media or internet, withdrawing from friends or activities that they enjoy, and then declining grades, change in mood, depression, anxiety, things like that are all warning signs that something may be going on as far as cyberbullying goes. We see a reduction in the total number of hours of sleep with our patients that are in adolescence. There's a shift to a later bedtime, and these patients are not getting the amount of sleep that they need. It's recommended that healthy teens get approximately 9 hours of sleep at night, and we rarely see patients who are actually getting that number of hours of sleep per night. We see a 40% reduction in the REM sleep stages from age 10 to 20 years old as well. So consequences of excessive daytime sleepiness, these patients can have mood changes, depression, irritability, trouble in school, they have declining grades, impulsivity, ADHD-like characteristics, and also death from motor vehicle accidents from falling asleep and being too tired driving to and from school. So as far as where we stand today, this is the most recent data about youth behaviors, and looking at this behavior survey shows kind of where we are as far as suicide and other risk-taking behaviors. So this goes through and it shows middle school students who have ever carried a weapon. So these are middle school students, and there's 34.2% in 2017 that report that they've carried a weapon. That's a huge number. You can kind of see the trend has been kind of within a few percentage points. It's declined from 2015 when the last survey was done, but it's still a huge number. And this is including guns, knives, things like that. High school students, interestingly, is actually less. We were at 20.5% in 2017, and that was the same weapons, gun, knife, and that's on at least one day during a 30-day period. So you can kind of see one day within the month. But that also is declined from 2015, but still a huge number, and interesting to compare that to the middle school kids that show that that's actually less than middle school students. Children who were bullied at school, we talked about this a little bit already, but the middle school students were at about 43.7% in this survey. So getting towards almost half of our students are being bullied at school. So it's always something that we like to talk about with our kids when they come into clinic, and make sure that if they do have anything that they want to discuss with us, that we provide them, skills and resources to be able to address those. Let's see. And then high school students was again lower, 21%, but still an important number to consider. When you think of electronic bullying, like I said, social media, email, text messages, things like that, we're at 23% for middle school students. So that number's been about the same for the last several years. So not too much has changed there. And then high school students, it's about 18%, and that number has actually been continuing to increase. And Instagram, Facebook, all those different social media outlets are definitely playing a role here. And when you look at high school students who have said that they feel sad or they feel hopeless, we're at 29%. So that's a big number. And those are students who it's been reported that almost every day for about 2 weeks that they've felt that way. So over a 2-week period, 29.2% of patients have said that they feel sad or hopeless. So that's a big number. When you look at middle school students who've ever thought about killing themselves, 18.2%, also a huge number. So I think it's so important to make sure that we're screening these kids, we're providing resources and doing whatever we can do to help from a healthcare perspective and making sure that they know what safety measures can be taken to help prevent these things from happening. High school students who've seriously considered suicide, 14.8%, and that was they ever thought that during the past 12 months. So also a big number and something that we want to make sure that we talk to these patients about when they do come into clinic. Patients who've had a plan in middle school, we're at about 10%, which is actually down a little bit from the last survey, but still, we, of course, want to make sure that these patients have the resources that they need and that we're accurately screening them to make sure that we keep them safe. And then this is the high school students, so about 13%. Suicide attempts in middle school is at 5.8% in 2017, which is down from 6.9% in 2015. So we're down a little bit, but still not where we want to be, of course. And then high school students are at 7.9%. Self-harm is actually something that we also make sure that we talk to our teenagers about. And you can kind of see here the middle school students who have done things to purposely hurt themselves without actually wanting to die. So females, this is a more prevalent concern with females. They're at about 21%, and then males are at 10, so about half when you look at female to male ratio. 8th grade is the most common age in middle school. They're at about 19% compared to 6th and 7th grade. But these are young kids that are doing these self-harm behaviors. So it's so important to screen these kids at a young age and make sure that we provide them the resources and things that we can do on our end to help to prevent these things. Hispanic is the most prevalent. White, 16.3%, and then African American, 12%. And then when you look at high school students, these numbers are huge. 12th graders are at about 58%. So over half of our high school students have, texted, emailed while driving a car. That's a huge number and can play such a terrible role in accidents and other risky behaviors. Males are more common, 37% when compared to 30% in females. So not a huge difference, but when you look at the 12th graders and over half have reported that they've done this, that's very concerning. And then high school students who've experienced sexual violence, females are more common at 14% when compared to males at 5%. Across the grades, you can kind of see it's about even. 9th grade and 11th grade are reported as the most common grades, but still significant amount in 10th and 12th grade as well. And then high school students who have used inhalants, female and male both are pretty equal in this. And then across, white, black, Hispanic, it's about equal as well. Self-harm, like I said, is definitely something that we see a lot of in our practice. And teenagers have this mentality of, my body looks how I feel. So these things can be anything from cutting, scratching, burning, rubbing, anything to purposefully injure their skin. Oftentimes they use it as a coping mechanism to deal with other different things that they're going through, and they're not always, their intent is not always to complete a suicide attempt or to have that be their main goal. Kids who self-harm are at a higher risk for suicide, but that's not necessarily exactly what their plan is here. It's an addictive behavior. It releases endorphins, so oftentimes our patients like how it feels, so they complete the behavior. But it's of course also very important to make sure that we're screening these kids for suicidal intent. And these are just some examples of patients that you can see who have self-harmed. You can see how significant these injuries can be, and it can lead to other things like infection, different other concerns that can arise from self-harm behaviors. So just some images there.
What's that middle one?
Oh, the middle. Is that burning, or is that?
I think it's a
Branding, yeah. Okay. Yeah, here. Sorry.
And sometimes that branding can be associated with a lot of different things like trafficking, which I know we're going to hear about a little bit later today, but okay. All right. And I apologize. I made some changes to the slide, so everything that you all might see is not, in your packets might not be here, but we like to talk about how to communicate effectively with patients. In every one of our offices, when the kids come in, there's a sign that says, please put your cell phone away, because we're trying to make a connection. But the problem is only 20 to 25% of kids, I feel like, actually look up from their cell phones to see it. So it's really difficult sometimes to communicate with patients, especially when they're on their phones, and that's what they're used to. They're used to communicating with their friends like that. That's how they do things. They email, they use social media, and less common is it to actually have a conversation with another human being. So a big thing that we talk about is the importance of active listening and making a safe environment in those cases, because whenever we're communicating with them, we're trying to kind of teach them what it's like to have a give and take communication and be an active listener. So it's really important to pay attention, listening for understanding, because as Kara had talked about before, there are several different perspectives, right, of different opinions and feelings and values, but there isn't always one right answer. So we try and instill that in our kids as well. Another key is responding to emotions. So 90% of 90% of how people look or what they're feeling and their body language is how they're actually communicating, only 10% of actually what they're saying. So reading into that is really good, seeing if somebody is nervous and expressing support for when you do feel as if they are being emotional, if they become tearful, if they become closed. So just kind of listening to those nonverbal communication skills. Demonstrating respect is really important. We talk about confidentiality with all of our patients, and you guys probably know that confidentiality is really important as far as letting kids know that everything that you say here isn't going to go to your parent. You know, when a family walks in, I had a patient yesterday, actually, and they said that they didn't like, a certain provider recently, and I asked why. And they said that she only looked at her mother the entire time during the conversation, and she spoke to her as if she was 3 or 4 years old, as if she didn't have any rights or any wasn't a player basically in her own health. So that's really, really important that we are explaining confidentiality, letting these kids know that we're the person that supports them, cares about them, and they kind of come first. Of course, with confidentiality, we let them know if you're at harm to yourself or at harm to anybody else, or if there's any type of abuse going on. That's when we do have to break confidentiality. So I think it's really important to establish that early on with kids. And then having an understanding of respecting where they are in their developmental stage. So a lot of these kids we're talking about are identity versus role confusion, trying to figure out who I am. And then cultural, religious beliefs, gender, sexual preferences, rights, and however they do identify wherever they are, we're always trying to kind of meet them where they are and not pushing them a certain way. So dialogue is really important. Barriers is, as far as eye contact goes, looking somewhere else would be a barrier. A facilitator would be maintaining eye contact or kind of mirroring what the patient does if they are looking down because they're nervous, to kind of pick up on those types of things. Body language, we don't want our arms crossed and to feel like, we can't have, exchange energy type of thing. And then leaning forward lets them know that we pay attention or we care. Communication patterns, if we're interrupting and challenging, it's not conducive to a good conversation. So being calm, staying silent, just listening, because sometimes these kids are the only place that they actually get to say what they want to say without being interrupted. And then as far as using words, not using medical jargon a lot of times is important in communicating without judgment. Is important. Being compassionate, validating it, normalizing the fact that, you're going through a hard time or this was a difficult breakup, because we all know that, in high school, you might not end up with that person, even though they think that that's the person that they're supposed to be with for the rest of their lives. Paths to avoid, even though we kind of talked about some barriers, basically acting like their parent because they have a hard time talking to their parents because they feel as if they're always kind of coming down on them and diminishing them. So, and of course too, when a family member is with them, not always just taking the side of the adult is really important as well, and not getting caught in power struggles, trying to see the perspective of more than one person. And then just with communication in general, I know Kara was talking about bullying before. 50 to 60% of kids we know are bullied. And one interesting thing that I've found in research is about 50 to 60% of people in workplaces are bullied too. So it's interesting because even though we're, transitioning through different parts of our lives, I think that conflict management is something that is really, really important and something that needs to be started early on and invested early on so that we can prevent some of these issues from happening. So as I said, identity includes a lot of different issues and things that we all need to take into account and be culturally and emotionally sensitive towards. Taking a holistic approach is recognizing the individuality of kids. A lot of times, I know I love algorithms and not having to worry about, this person or that person, but every person is an individual and unique. So hearing them and listening to them is really, really important when we're being holistic and looking at the full person. As far as seeing things from teens' perspectives, trying to be empathetic of them is important. And then, there are a lot of psychosomatic symptoms that they might have. Is this purely physical, or is this because they are experiencing a lot of anxiety and depression? Is that causing their abdominal pain or their headaches or whatever the case is? These are some of my favorite, or some of really, really good questions to kind of have open-ended questions and talk to kids. If I asked your best friend what you're like, what would you say? What would they say? What would you do if you weren't in school? What do your mother and father do when you're not there? What do you do well? What do you do when you finish school? Where do you see yourself in 5 years? And my favorite question to ask kids is, if you can change anything about your life, what would it be? And I get a range of answers for those. The one that I get very frequently is, I wish I could change something about my body, having poor self-image and wanting to change the way their nose is, or wanting to change how big or small they are. And for guys, they a lot of times want to change the size of their body. They want to be bigger and buffer. So this self-image is not a female problem either. And then I get other answers such as, I want to change my family. I want to change everything about my past. I want to change, I want to have a dad around. I want to have a full family. I don't want my parents to be divorced. So a lot of times whenever they're struggling with those situations, I think that that's a good time to intervene and maybe do some counseling and talk to them about that. The other answer I get is I don't want to change anything about my life, which is always a nice response. And then because they do feel pretty happy and fulfilled. And then my favorite answer is when a kid says, I want to make other people's lives better. That's the sweetest one that I get. Because public health is so much ahead of the curve as far as what we know as far as prevention. You all probably know about the ACEs study. Who has heard of the ACEs study? Okay, great. So the ACEs study was they took a group of people from 1995 to 1997 in California, and they were middle-class Americans with health insurance, and they looked at the chronic diseases associated with their childhood adverse experiences. So it's a really, really, really big study. It's one of the biggest studies within the public health realm. And what they found was that when you have adverse childhood experiences, so physical abuse, sexual abuse, neglect, household dysfunction, all of those things, basically what happens is you have this disrupted neurodevelopment. So like Kara was speaking about earlier, we're already, having a lot of changes within our brains during adolescence. So then with this additional stress that takes place, that alters it even more. And when that alters that, that chemistry and it kind of changes the architecture of our brain shaping, then we have problems with social, emotional, cognitive regulation as well. And then what happens when we're not thinking clearly and we're already an adolescent, then we make bad decisions or even more impulsive behaviors than what we already would. So, we talked about the roller coaster and stresses and what happens when we have these high-risk behaviors, when we're drinking more, when we're smoking more. All of that goes to, that turns into chronic illnesses, diabetes, COPD, all the things that suicides, mental illnesses, depression. So basically what we found is that this adversity causes 20 years earlier death. So if you have 4 or more ACEs, you lose 20 years of your life off of the U.S. lifespan, which is this was an unbelievable study. And we talk about stressors, there's really healthy stress. I have my watch to let me know whenever my heart rate goes over 100 when I'm not being physically active. Of course, as I was sitting here super nervous, I looked at my watch and I saw that my heart rate was going over 100. But a lot of these kids run at heart rates high because they're just always in that mode of not knowing what's going to happen and being stressed out and having a really negative response, because stress is necessary. We talk about bones and how if we just laid down all day, right, our bones would never build, but we have to walk and we have to move. But then if someone were to put a 500-pound ton on top of our head, the bone cracks. So having enough stress is good, but having too much stress will completely break a person too. So as I said, adverse childhood experiences, there can be 3 types of abuse: physical, emotional, social, neglect, physical or emotional, and then household dysfunction. Mental illness, incarcerated relatives, mother treated violently, substance abuse, and divorce. Can anyone guess what state is number 1 for parental incarcerations? Which state? Yes, Kentucky. So that is a big one, and we see a lot of patients that have parental incarcerations that are growing up with their grandparents too. So we learned 3 things about the ACEs. One is that everyone has ACEs. So 66% of the population has at least one, and usually a household dysfunction. We know that. Another thing is that they cluster. So once you have one, you're high likelihood to have another. And then the third thing that we learned is that we have a dose response relationship. So the higher your ACE score is, the more health effects that you have. So does this work? Yes, okay. So if you have greater than 4 ACEs, you have you're 2.2 times more likely to have heart disease, 1.9 times more likely to have cancer, 1.6 times more likely to have diabetes, and all these things just being that we are negatively coping. The biggest findings, I think, here is if we have more than 4 ACEs, we're 12.2 times more likely to attempt a suicide and were 10.3 times more likely to inject drugs. So we can't talk about prevention of suicide without talking about ACEs because of how important it is to kind of have the importance of stability. And if we don't have stability with adversity, then we have to be able to build resilience within the family. So the probability, if nobody has ACEs, they're 1 in 96. 1 in 96 might attempt a suicide. If they have 1 to 3 ACEs, 1 in 10 attempts a suicide, and then 4 to 8 ACEs, 1 in 5 attempts a suicide. And then again, smoking, alcohol, IV drug use, heart disease, all of those goes up. All of those go up based on your ACEs. So toxic stress, like we kind of talked about before, with increased heart rate, changing the way that the architecture of your brain is, it affects from early development, especially your neurologic regulation, your endocrine signaling, cardiovascular, resistance. And epigenetics, I think, is one of the most interesting pieces here because, we did this massive human genome project, and it turns out that humans are about similar as far as genetic uniqueness to a leaf. Not to say that humans aren't great, but what we found is that it's more than just genetics that create the health outcomes of humans. It's the epigenetics. So basically, if you take a kid from a harsh environment and you pick them up and you place them into a loving home, you're going to have outrageously different outcomes, regardless of what the genetics are. And that's not for everything, but we have found that is the case. Toxic stress effects include altered cardiovascular regulation, things that Kara talked about, impulsivity, anxiety, increased total response, sleep problems, which all of these things make it easier for kids to have mood disorders because we're not having sleep, we're increasing that threshold or decreasing that threshold for having suicidality. Effects on relationships, they have difficulty forming positive relationships, poor sense of self, poor sense of esteem, not knowing who to trust, and then not having a secure base and expecting that the way they've been treated is how they're supposed to be treated because our brains fire the same, the same signals. And sometimes if someone is in a normal relationship, or I don't like to use the word normal at all because I tell my kids, if you're not weird, you're weird. There really is no normal. But if you're not in a stable, if you haven't lived in a stable setting your entire life, and then you meet somebody and they're treating you normally, it's not stable, then that doesn't really feel familiar to you. So sometimes that doesn't feel right, and we just kind of go back to what we've known throughout our childhood. Now, nationally and statewide, we are doing the behavioral risk factor surveys, which is great. And in 2015, we actually added ACEs because we have an understanding of how important these are. This information is to gather. So asking about physical abuse, sexual abuse, emotional abuse, household dysfunction, and parents answer the questions in these surveys. In Kentucky, 30% of children have at least 2 ACEs, 22% nationally, so we're above average for everything compared to nationally. 1 in 5 with greater than 2 by age 5, and 1 in 8 is national. Kentucky children's ACE score is greater than 3, one of the highest rates in the country. So this is just a kind of quick and dirty view of what it looks like to have a high ACE score. So at the end 3, and this is the one I really wanted to bring up when we're talking about preventing suicide, depression, these are the numbers. So if you have 1 to 2, or greater than 3, we're way higher likelihood of having a prevalence of underlying depression. I don't know if you all can see that. This is ACE score and attempted suicide during adolescence. It is a massive number. Greater than 7 ACEs, 14% risk of having a suicide. I'll show you this really quick too. An ACE score of 4 makes a person 12 times more likely to commit suicide. An ACE score of 7 or more increases the risk of 30-fold in adults. And then for 7 for children, teens, because of that developing brain, because of the increase in impulsivity, 51-fold, increase the risk 51-fold in suicide attempts. So one of the things that I do in practice, because we always ask ourselves, would this kid actually do it, right? I mean, is this kid being serious? Which first off, we always need to talk to the kids and take whatever they say seriously always. But this is something that we need to really know and screen for, so that we know how dark are they, how, you know, how upset and frustrated at life, and are these adverse experiences continuing? Because if so, those are not good odds at all. Then it's very scary. This is really interesting when we're talking about prevention as well. 2011-2012 National Survey of Children's Health took ACEs from the population and from the parents' report, and the lowest prevalence of 4 or more ACEs was in New Jersey and New York for 4 or more ACEs. They were ranked number 49 and number 50 for suicide, so the lowest amount of suicides, which I think is fascinating. For adolescent rank, it is a little bit different, but they correlate pretty well. All of the states do, and why is that? Is that because of genetics, or is that because we're around family, we see family do this, we're probably more likely to do it as well, either commit or attempt suicide. Highest prevalence of 4 or more ACEs was in Oklahoma, Montana, and West Virginia. Oklahoma, West Virginia, excuse me, were number 11 on suicide rankings for that corresponding year. And then Montana was number 2 in total suicide rank for the whole year. And then adolescent was 12, 5, and 1, but well above the national average. So we can't not think about ACEs again when it comes to suicidality. Not necessarily related to suicide, but in the blue you'll see the results of how frequent these ACE scores are. So around 35% of people don't have any ACEs, then 25% 1, 15 to 18% 2, and so on and so forth. So we kind of dwindle down. But when we're looking at juvenile offenders in Florida, most of the kids there have 4 ACEs. So it's very rare that we're going to have somebody that's never had adversity in their lives that are part of the juvenile system, which is interesting. So when we're talking to kids, instead of saying, you know, these are all the issues happening with you, why are you being impulsive, why are you not getting good grades, why are you not getting good sleep, instead of saying what's wrong with you, what are all your symptoms, we're asking them what happened to you, and being a good listening ear, because it's important for them to know that just because they don't feel normal, that there might be a reason for that. Interventions as far as having high ACE scores, just normal routine things, regular exercise, good nutrition, sleep, mental health, you know, of course, providing patients in our clinic with resources as far as counseling goes, mindful practices, and supportive relationships. So we know that things of course like meditation, we can decrease the inflammatory mediators and the increased heart rate and all those things so much with things like meditation. And kids, when we say meditation, kids are like, I'm not going to sit down and meditate for 10 minutes, but doing things like mindful eating. So just tasting the food, enjoying, you know, the outside, just taking a walk and putting your phone away, just being, you know, in the earth and not being connected to something else is how we can experience mindfulness. And then of course, supportive relationships, because we know as humans, we can't live in isolation. We cannot expect to thrive whenever we're living in isolation. So these are just some normal things. I'm not including medication here because most of these things don't require medication. It's just about routinely giving kids what they need in order to thrive. And it's not complicated. It's just the things that they should get every day. So how do we screen? Dr. Robert Block, the 2013 AAP president, said adverse childhood experiences are the single most greatest unaddressed public health threat facing our nation today. Pediatricians should actively screen for precipitants of toxic stress that are common in their particular practice. So how many people, like the percentage of pediatricians that don't ask about any adverse childhood experiences is about 36%. It's a lot. Greater than 30% of pediatricians don't ask about sexual abuse, which we know is one of the huge factors associated with suicidality. So if you don't ask, you don't know the answers to those things. And sometimes I think pediatricians are nervous to ask, or any health providers, because, well, what do we do if we get a high score, or we know that something's going on? We're going to have to make reports on things. We're going to have to offer them mental health services, but we have to have the ability, just as, as a community, to be able to know that we have to ask the questions in order to address the issues that kids have. So we do a PAR screening in adolescent medicine, and it talks about everything from drug use to abuse to, what their future plans are. So we ask all these kids these questions. So it covers a lot of those. PHQ-9 is a great screening tool. I don't know, if anybody administers these, just to know risks and how severe their depression might be. We also do a generalized anxiety screening as well. But the two big things that a PHQ-9 does have on it is, one, have you had any thoughts of suicide in the last month, which is telling, and then two, have you ever had any past suicide attempts? Because past suicide attempts are the biggest predictor of any future attempt or completion. This is the actual ACEs. I was listening to a TED Talk, and I would recommend it. It's Dr. Nadine Burke-Harris, and she has a practice in San Francisco. And her and her practice, they started doing ACEs on their patients and providing a lot of resources based on what their ACE score is. But it's really interesting. A lot of times I'll have participants actually do an ACE score, and we can talk about it, but I'm sorry, I did not prepare well enough to be able to do that. But it's really interesting. So these screenings can easily be done in school settings, as long as there is confidentiality or their agreements. But something easy and simple to do, and kids for the most part will be pretty open about it. The other nice thing is that it's de-identified. So basically, out of the 9, they just write the number in. So it doesn't really go into which one it was screened for. We just know the number. When we understand that the sheer number is really important for chronic health issues, so that nobody would have the excuse of, I don't know what to do if this person, has this going on. We just kind of move to the next piece. We know that stress can be it can be unpredictable, severe, prolonged, which creates vulnerability, or it can be predictable, moderate, controlled, which creates resilience. So again, we have to have stress in order to grow, but the increased amount of stress does lead to vulnerability, and especially vulnerability to chronic health conditions in the future. And this is just I don't think, let's see. Oh. Sorry about that. I don't think we're going to. Okay, I don't think we're going to be able to watch the video, but let me pull this back up here. Okay, so that was just a video on resilience and the importance of instilling resilience in kids and families. So how do we instill resilience? Because if all the chronic stress that's associated creates vulnerability and creates an increased risk for suicide, then what creates strong people is resilience and having the tools that you need to be able to succeed despite adversity. Because I don't know if necessarily the answer is completely taking away all adversity. I don't think that we can live in a world that has no adverse experiences. I don't know if we could even pretend to do that, but what we can do is instill resilience in kids, and that includes a lot of different things. That includes parental resilience. A lot of times I'll give ACEs screenings to the parent and to the child. So I had the parent answer the questions to see what their score is. most of the time their score is higher than the kid's score. A lot of times it's similar, and I enjoy the times where a parent might have an ACE score of a 6 and their kid has a score of a 0, and that is a resilient family. So how do we do that? Parents have to be able to manage stress when faced with adversity and trauma, and have the tools to do that. We have to be able to build social connections as a community and a state and a nation. We have to be able to understand child development and, understand proper parenting and, development of adolescents in order to properly meet the needs of where they are. We need concrete support in times of need to family services and all those types of resources that we should be able to provide our patients with. And then we need to understand the cognitive and socioeconomic or emotional competence of children by supporting good relationships as well. Building blocks to human resilience include physical and psychological health of the population, social and economic well-being, individual, family, community knowledge, and attitudes regarding self-resilience and self-help, effective risk communication, socially integrating government and non-government organizations, doing what we're doing now as far as collaborating of the best ways to address these issues, and listening to our youth advocates. When we have our Stop Youth Suicide Conference, which you are all welcome to come to in November, we have a youth panel that sits, and they have the best answers to the problems of the world because they have such fresh minds. So that should be part of our collaboration, is involving youth with us too. We need better active stakeholder engagement, social networks, health promotion opportunities, understanding vulnerable populations and meeting, those vulnerable populations with these types of resources, and strengthening and rebuilding the health and social system. This is a really interesting framework on early childhood policies and programs, because what we see is that ecology, or the environment that we're in, actually shapes the genetics of our kids. It changes the way that our genes are expressed, and all of these changes are embedded during these sensitive periods. So we talk about 401ks or investment. We know that investing in our retirement early is how we grow it, and it's no different than in the public health and social realm of the United States as well. So incorporating good policies and programs for innovation, caregiver and community capacities, foundations of a healthy development and environment all shape the way that our children and our youth grow up. So that's what creates outcomes. And I think that having that knowledge gives us the responsibility to help shape that a little bit better, because what the current paradigm that we're in now isn't doing the best job of that, I think. And I believe that we're all sitting here, at least 66% of us have had at least one ACE. A small majority of us have had many ACEs, and we're still here because we're resilient and because we care about improving public health and helping out our kids. So I think having that knowledge and knowing that is really, really, really important in shaping our youth and being really huge advocates for our kids. And I'll jump on my little soapbox really quick as well, in that the United States spends $10,000 per head on health care, right? It's about 2 times as much as any other developed country that there is. So we're spending double the amount on health care. And one of the biggest, and there's a lot of factors related to that, but one of the biggest factors they found is in developed, social developed countries such as Germany, Norway, New Zealand, places like that, is that they're spending $2 more for every dollar that we're spending on public health and social development. And so we're spending double the amount, and we're spending half as much on doing things that are intervening and are that are not investing. I think in medicine we have this this acute or crisis mode all the time, and public health is the
beauty and the exact opposite of that. And I think a lot of providers and medicine in general is stuck in crisis mode. The word prevention and suicide shouldn't even be in the same sentence, right? Because that's the end of a lot of struggle for kids. So, hopefully being able to support public policies and doing things of that nature are going to be the real things that do it. And I don't think there's one group that has a responsibility. I think that it's all of our responsibility. So the CDC brings up preventing suicide, and it brings up a lot of the topics that we cover just in ACEs in general. So strengthening economic supports by strengthening household financial security, helping economically what we're doing and with our families, strengthening delivery of suicide care, coverage of mental health conditions by insurances, reducing provider shortages, especially in psychiatry and psychology, safer suicide care, creating protective environments by creating community-based policies, changing our culture, promoting connectedness, promoting coping and behavior skills, identifying, supporting people at risk, and then lessening harms to prevent future risk. So safe reporting, helping with gun control, making sure that families know how to keep their kids safe too, because I think all parents want to do the right thing. I think all of our parents love our kids. I just don't think that they know the best way to do that sometimes too. And I think that providers feel the same way, nurses feel the same way. We just want to be able to have the tools that we need to keep our kids safe and happy and lead resilient lives. So a couple of quotes before we close out. Frederick Douglass said, "It's easier to build strong children than to repair broken men," which is very true. If we invest early, we can take care of a lot of these problems, including chronic diseases. And then Andrew Gardner, the AAP president, says, "We see how early childhood experiences are so important to lifelong outcomes, how the early environment literally becomes embedded in the brain and changes its architecture. Hopefully this will drive support. It's not just the right thing to do ethically. It's not just the right thing to do economically. It's the right thing to do biologically. And the framework places it squarely in the realm of pediatrics." So these are just some resources. National Suicide Prevention Hotline, and then prevention of bullying. And then this is our information from UK Adolescent Medicine. If y'all ever have any patients that, or you know of anyone, you can always send them our way or reach out to the state resources as well too. So these are some bills that are going on in Kentucky, and that is all. Thank you for your time.